Welcome everyone to this meeting of the Economic Policy Working Group with Casey visiting us. I have to clean up my screen here. And very honored today's talk. He's a prolific author. I like his book, You're Hired. It's a great one, plus Redistribution and Recession. Professor at the University of Chicago. He's visiting Hoover right now. He's in his office at Hoover as chief economist of the Council of Economic Advisors. And he's doing exciting work that we're all interested in. And the title of his paper, you can see it on the screen, The Backward Art of Slowing the Spread, ? Congregation Efficiencies During COVID-19. So welcome, Casey. Casey's going to talk for 40 minutes or so. You're welcome to interrupt, especially on factual things. And then we'll have a good discussion afterwards. So welcome, everybody. Casey, the floor is yours.
Thanks, John. Thanks for hosting me. I really enjoyed visiting here. I thought I would start with a quote. Mitchell was the founder of the National Bureau of Economic Research. And basically what he was saying over a century ago is that for many activities, home production is amateur hour. And it wasn't that difficult for him or his parents to remember when rural families were doing almost all production at home and not doing it as well as would later happen in a factory. Now, well after Mitchell said this, we still have China's so-called Great Leap Forward, where the peasants were ordered to make steel in their backyard. And a lot of effort was put into that, tragically, and nothing came out of any value. It's obvious to us, I hope, today that steel is something done on a scale much bigger than a peasant's backyard. And so the question...
Much worse, Casey. There are millions of people died for the Great Leap Forward. Starvation.
Right. It was a tragic mistake to think that steel could be made on that kind of small scale. And the question I posed in this paper is whether infectious disease prevention is better produced in the backyard, so to speak, or in the factory on a larger scale. So epidemiology has something to say about that, and it's not my field, but so does economics. Let's take the economic theory of public goods. That's relevant here because prevention behavior has an element of public good. My prevention potentially creates some kind of benefit for many other people, maybe everybody. And the theory says, I'm referring to Samuelson's theory, take any list of names and the demand for public goods by those on the list is much greater when the list members cooperate with each other. This is one of the strongest predictions that economics has. Yes, we have the law of demand, but that's just qualitative, at least the substitution effect part of it. But Samuelson's result is quantitative. It says that if that list of people were, say, the students, faculty, and staff at Stanford, that would be more than 30,000 people. Samuelson says that's 10,000 times the willingness to pay they would have if they were cooperating rather than being in much smaller groups like a family of, say, size 3. Of course, disease prevention is not a pure public good because it has a local element to it. And this changes the quantitative prediction in interesting ways, but not the qualitative prediction. More important is that cooperation, of course, is easier said than done. And that's why when a pandemic comes along, I don't recommend making random lists of people and advising them to cooperate. But people have already been assembled into groups where they cooperate for other things, which significantly raises the chances that they can cooperate on something new. And the workplace, also schools, is one of those places. Then on the supply side, also may be different in groups. And that, in the steel example, that's maybe the more obvious side of things, that there can be scale economies. And when I start to show you some of the prevention activities that are actually being done with respect to this disease, you'll obviously see that there are scale economies involved. So let me give us a little bit of notation to discuss this a little more rigorously. I want X to refer to prevention effort and the size of the group. So N would be a big number for a workplace like Stanford and a small number for a household. And there's going to be some costs per person from the disease. There's more to life than disease, of course, but the disease part of the cost, and it'll depend on the size of the group and on prevention effort. And I'm going to embrace the idea that, holding constant prevention, a bigger group could be a more dangerous place when you have an infectious disease spreading. There's going to be a cost to prevention, and C is going to be the total cost, and then C over N are going to be the per member costs. And we're going to, of course, want to compare that to what prevention might do to the cost of the disease itself. So an equilibrium will, of course, involve a trade-off between the cost and the benefit. Here I've added, when it comes to equilibrium, SN, that's the share of the social costs that's private. And that's going to depend on the size. That's Samuelson's idea that the bigger the group is, the more the costs are internal to the group rather than external. So that gets added in here, but then the equilibrium calculus from a private perspective would be, well, what's the right amount of prevention that trades off the disease benefit of prevention with the cost of supplying that?
Casey, this is equilibrium. This is individual optimum. Is that right? Not really equilibrium.
Well, not, let's say private group. I'm not going to dig inside a group like Stanford and figure out how do all you guys cooperate.
So this is the planning problem optimum for the group.
Yeah, but Stanford's not the country or the world. That's going to be an important distinction. Yeah. So the equilibrium I just copied from the previous slide. Then we can think about the disease gradient. And the relationship between group size and equilibrium cost is not the same, even the same sign as the relationship between disease cost and the group size. The disease gradient can have either sign. There's really two parts of this. There's an epidemiology part, the FN, that says holding constant prevention, big groups have a bigger problem with infectious disease. But then there's the economic side that says, well, maybe big groups do a different amount of prevention on a per person basis than smaller groups do. So those are the two parts. And of course, we need to compare and think about which one might be larger. And that's why this is going to be a heavily empirical discussion. The last little bit of theory here is we can sign the equilibrium gradient, the total cost gradient, at least in the neighborhood of zero prevention. And that's increasing. So even though the larger groups might be safer in the sense of having less disease, they're still going to be more costly. And that's important from an externality perspective, because people are going to have incentives to avoid the total cost, not just the disease cost. And so we can have a situation where the larger groups are, number one, places that people want to avoid, and number two, are safer. And therefore you have kind of an interesting externality that being part of a large group actually has a positive externality on people, on the economy as a whole. Here's a picture to illustrate this. The x-axis is the size of an organization. So we put households more toward the left, businesses more toward the right, depending on their size. We could put nursing homes and hospitals on here, which I discussed a little more in the paper than I will today. Because in case you didn't know, there's hardly any nursing home that's as large as the smallest hospital. They're very different sizes of organizations. And then the y-axis, we have costs on a per person basis, and they're both these types of costs we're going to show there, both the disease costs and the costs of prevention. And I have the upward slope here in terms of the cost of, on the disease side, the private part of it, and it slopes up for the two reasons. One's the epidemiology reason, and the other is the part that, well, the larger groups internalize the greater fraction of the disease costs. Now let's think about, for the purposes of this picture, we did the calculus already, but for the purpose of this picture, let's think about just one prevention action. Are you going to take this prevention action or not? And if you take it, there'll be lower disease costs. That's the point of the prevention. And the difference between these two is the benefit of prevention. And I've drawn that here in solid. And that's sloping up for the same two reasons we talked about. So what size of an organization will find it optimal from their perspective to undertake the prevention? Well, that depends on the cost curve. And I've drawn, following Viner, I've drawn just a kind of a U-shaped cost curve, average, per member cost curve. And I've drawn it in the interesting case where it crosses the benefit. So we have a range of sizes of organizations that will engage in prevention, and then a range that don't. And I can graph here, I'm going to make a thick line to graph the disease gradient in this picture. There's going to be a high disease in the small groups who aren't preventing, low disease in the middle groups, and perhaps there's a very large size group where they're also not preventing, and they have particularly high disease costs.
Casey, can I ask a question?
Yeah, please.
There's if I understand correctly, the implicit assumption here is that the baseline rate of interaction among members of a group is the same across all groups, regardless of size. Before aside from any prevention efforts, is that right? And
no, well, no. F does not have to be like a combinatorial formula that says how many pairwise combinations of Stanford community members can we have. It might be different from that because there's some people on Stanford I'll never meet because we don't have much in common. We're not near each other. The main thing I assume here, and I'm embracing the epidemiology view, is that F is increasing.
Yeah, but what if F varies across organizations in a way that's systematically related to their size? That seems plausible. Then that would at least make the implications more murky. I'm thinking about it correctly.
Well, we can have things like some organizations are also living quarters, like a nursing home or a college, and that might have a different F. That's correct.
Casey, I also got a little lost on the scaling properties of F. I can see as you get a little bit bigger in an organization, more people run into each other, so it's more likely to get sick. But eventually, I think where Steve was going too, I mean, the constant returns to scale at some large size certainly has to kick in. Once you're talking about a country, it's certainly something has to be linear in the number of people, or the cost per person is unaffected by size, because I don't meet anybody in Washington, D.C.
Well, that's kind of how I drew it here. It gets pretty flat at the. This is a per member thing. So, John, you're talking about a horizontal cost line here.
F of N, this is where I was. F of N is the cost per person.
Yes.
So constant returns would be a flat F of N. Okay.
Yeah. In this picture, right.
And the reason for increase isn't so much the cost changes, but just the chances of infection change when you're in a group like that. But you also get infected from people who are outside of your group. So I don't know. I wasn't quite clear why F of N should rise at all.
Well, think of for example, the combinations formula. How many pairwise interactions can you have?
Okay, if you spend your whole life within a group, but you are you are biologically walled off from people outside of the group, but the whole, like nursing homes, the problem was they didn't get sick at nursing homes. The nursing home attendants went home and went to bars and they got sick there.
Well, actually, they went to other nursing homes, which is part
Oh.
of the problem. I mean, they're small organizations, so they have a lot of people who are going between. You know, there's maybe some lady who does nursing home A on one day and then nursing home B on Tuesday and so on. And she was moving it. There was a study, Chevalier had a study of cell phones showing that. And that's more in the S term, that the nursing home doesn't, its scope of its control is too small. I mean, it's small and they can't control what goes on off site. Whereas a hospital, they don't have that type of thing because they're much bigger. And they would police how much people going from radiology to podiatry or whatever. They had rules around that. And they can do that as a bigger organization, and they do have that incentive through that's really the Samuelson term. So that,
anyway, I don't want to fight about it. Now I'm understanding it, what the thing is. And why does the cost have this U-shaped thing? It's just economies of scale for a while and then diseconomies of scale? Is that the?
Yeah, I mean, certainly when I show you the examples here, you'll see the downward sloping part. Whether there's an upward sloping part, maybe not. And then you would not have an N2. Even the very large groups would be doing the prevention. That's fine. The surprise part here is what's going on to the left and to the right of N1. That, oh, gee, you have the small groups like households who actually have a lot of disease compared to this bigger group like the school.
But that makes a lot of, as you said, there's fixed costs, there's economies of scale, there's getting the tests out, making tests. You need someone who knows how to do it. Okay, good, thank you.
Yeah, especially when you shut down the market, as we did, as the FDA did and does, economies of scale get to be even more important because, the U of I could make tests for itself, but it couldn't sell tests in the market generally, right? And so
we do that right now. You can get tested for free at Stanford. Very quick result. Nobody else in the country can get tested right now.
Yeah.
In the paper, you have this parameter that converts pairwise interactions into health costs, this V, in the same figure. But because V doesn't vary with any of the things in this figure, you've taken it out to show it to us, I guess, for simplicity. But isn't, in a sense, these comments? I mean, the V is what links any pairwise interaction to I guess infections or ultimate outcomes. And I guess all these comments could sort of be seen as asking whether that V is related to organization size.
Yeah, although the V I wanted to take separate from the organization size. I want to compare things like flu to COVID, because what some economists did is they looked at the data on the flu and they said, look, flu spreads a lot in schools and less so at home. So let's shut down the schools. But the economists would say, wait a second, you've changed. When the costs are low, nobody will engage in prevention. So then the epidemiology kind of dominates. But when the costs are high, now the economics comes in, and as you increase the severity of the disease, the first places to prevent will be the big ones. And the small ones will be kind of last in line. So that's kind of was the purpose of the V, which you can't see here, but Jonathan saw that. I think it's important in comparing to the flu. They might be biologically the same in many ways, but they're not economically the same, and therefore they're not going to be the same in a world of humans, doing their thing. Okay, so now that's enough theory. What about data? Here's a measurement framework they're going to use. We're going to think about a location and a time interval, say a school or workplace for the workday. And there's going to be some infectious members who come from outside that location at 9 a.m. and show up on site with the infection. And that's the first two terms. There's a certain number of members who were infected, and the location may screen or not people from coming in. That's kind of the second term. And then the third term is, they're going to make some contacts when they're there. And that's the scary part about schools and workplaces, that there's so many contacts happening. And my data is going to confirm that. Lots of close contacts happening at school and workplaces compared to homes. And then the last part is, well, contact is not the same as getting the disease. And that's the secondary attack rate. And you'll see from an economic point of view, we kind of like to think of these things per unit time, especially for time allocation questions. So I kind of move the time part over the left-hand side and talk about infections per member hour. And that still you have these same 4 terms to talk about. So the big organizations potentially in the data are going to have the disadvantage on that close contacts term, but the prevention is going to work on these 3 things. They're going to be screening, doing things to reduce the secondary attack rate, and maybe also reducing the contacts. Although in the end of the day, in the equilibrium, the large groups will still have more contacts, at least as far as I can see in the data. So I have 3 types of data from several different studies and some of my own data. My favorite data are the ones we can trace to the source. My good news is we have some of my favorite data. Bad news is it's in limited supply. And so there we see people who engage in in-person work or in-person schooling. We can see, oh, they're infected. Where'd they get it from? So that's nice. The second group of studies that we have, which have their uses, compare the infection rates among people who participate in in-person activities to the general population. This is the type of work that Emily Oster was doing, and it's useful as well, but it's not tracing the source of things. And then the last group of studies are on the secondary attack rates, where they find instances where an infection came onto the premises and the person made contacts, and how many of the contacts ended up taking away an infection. Okay, the first empirical results about prevention effort. That's the centerpiece of the theory. And so, in fact, organizations did a lot to prevent. Now, this slide doesn't tell you whether those actions worked, but they were doing a lot of things. My favorite is what Amazon did, which included video surveillance. So if an employee tested positive, they could go back to the tape, so to speak, and see who were the closest contacts. Maybe it's a little creepy, but only a large organization could do something like that. You're not going to have that kind of system set up in your house or in your small business. Now, did these efforts work? That's the next question, and that's kind of the picture behind me, and I'm going to put it in front of you guys. So this is a graph of my favorite type of data, which has tracing it to the source. So the vertical axis here is measuring hourly infection rates in these 2 places, at the workplace or a school, compared to outside the workplace on an hourly basis.
AC, could you just clarify what you mean by tracing it to the source? So this is really, we survey everybody, we know everyone who's got COVID, and we figure out who they got it from?
Yeah, we go backward contact tracing. It's an expensive exercise, so
yeah,
that's why it doesn't get done so often. In fact, the Duke team, Duke Health, I should say, it's not just a hospital, it's a very big health system. They have a number of hospitals and clinics and doctors' offices. And they have their own epidemiology department, and who includes a number of academics who like to publish studies, and they did the work to trace infections in that health system. They also volunteered their services to the North Carolina schools, not all of them, but an awful large number of them, and they worked on tracing infections in the schools as well. So the Duke team actually prepared my first third of this picture and the middle third. And the last part was a study from some schools in Wisconsin. What's nice about the Duke study, in addition to tracing this source, is we have a before and after. So when COVID first came into their community, they weren't sure what to do. And like a lot of hospitals, they were getting a lot of infections. Doctors and nurses were getting COVID, and they were getting it from work, and they were getting it from patients, both COVID patients and maybe incidental patients. But within few days, several days, they said, we got to have a plan to prevent here, and here's a laundry list of things we're going to do. And bam, their infection rate drops almost to zero. In fact, you can count them with just a few fingers on a hand, the cases that happened after that. And these were a couple nurses go to the lunchroom and take off their masks and eat together for an hour when they were not supposed to do that. And a case happened. For the schools, we don't have the before because the governor's closed all these schools, but we do have the after. And in these schools, it's observed overwhelmingly. Yes, students and teachers get COVID. Overwhelmingly, they got it outside of school. Even on an hourly basis, of course, most of our time as students and teachers is not spent in school, but even on an hourly basis, more outside of school.
Casey, do you have other data that look like this? Is this this is one example of sorts.
Yeah, well, three examples. Then we end up moving over to kind of the Emily Oster style of study where we look at, well, people who participated in person, do they have lower infection rates than people who don't? And they do, and it kind of lines up with this once you recognize, that Emily's type of data is a mix of infections at work and inside of work and outside of work. You recognize that they spend how much time they allocate between those two. Lines up very closely, which I show in the paper. This is actually some of those studies, John. I wanted to point out the meat packers. That's my other before and after. So the meat packers also had very high infection rates relative to the community. They took a few actions and they brought them way down, although they still ended up being higher than the community, but they brought it way down. So these things, we're not exactly sure what works, and people argue because of course they're throwing the kitchen sink at the problem, but something in the kitchen sink is working. Okay, so let me talk about the secondary attack rates, and then we can go to more discussion. These first part, in the lingo of the field, these are called the index cases. These are the cases that come onto the premises from outside and potentially spread to the others. And that they make some contacts, and we measure that in the secondary attack rate studies. And then each contact results in an infection at a certain rate, and that's the secondary attack rate. And table 4 has that each row here is a study, and each column is a different element of the measurement framework that I already showed you. The secondary attack rates in the last 2 columns. And just remember, a secondary attack rate has its numerator, the number of secondary cases, and its denominator, the number of close contacts that the index case has made. Let's distinguish workplaces here in green from households in red. You can see orders of magnitude smaller secondary attack rates even on an hourly basis in the workplaces. But you see what we all expected, the epidemiologists told us, you're going to have more contacts at work and at school. It's true. It shows up in the studies. Even in the equilibrium with the prevention, there are a lot of contacts being made, but these contacts don't turn into cases at much of a rate. And this has been well known in epidemiology. Somehow it doesn't get added into the policy discussion very much, but it's well known that households have the highest transmission risks. These are quotes from epidemiology studies, and they're kind of fitting with what I said. So we see in the data, the large organizations have this disadvantage of having lots of contacts, but we also see in the data the prevention, and we see results. which is low infection rates compared to what happens outside of workplaces in schools. So, and to conclude, workplaces and schools, they're taking actions and they seem to work. The infection rates are lower. Why? At some level, the screening I think is important. The index cases aren't allowed in, and the low secondary attack rates. Is that achieved with masks or distancing or whatever? I'm not sure. And in this situation, work has a positive externality. The private incentives are to stay home. We had people, students at the University of Chicago last year, we were open, but students could stay home if they wanted, and some did. And like, it's such a rigorous dorm life that I'd rather stay home where I'm free to do what I want to do. And then the last point, we have less evidence on, but it's an interesting question. Are the large employers safer than the small ones? I think you can see a positive answer, at least when you think about the nursing home hospitals comparison. So good, and let's look forward to your comments.
So if you have a question, raise your hand or shout out. Go ahead, Steve.
Thanks, Casey. That was super interesting. There's more a comment and maybe to elicit your reaction. When I think about the role for policy, one place where we fell short, and I guess maybe still are, is promulgating what's known about best practices in these mitigation and prevention strategies. So it's hard to think back, but you know, back in March, April 2020, there was tremendous confusion about even basic things like if you ate outside at a restaurant, was that reasonably safe? There's continuing controversies to this day about how effective masks are and under what circumstances and so on. So one policy failure that I don't see getting much attention is if there had been a greater concerted effort and coordinated with good communication to just promulgate best practices. Organizations, a larger share of organizations would have taken up some of those rather than using the kitchen sink approach, which is obviously expensive and rather demanding in terms of its organizational requirements. So I'd just like to get your thoughts to that about that.
Central planning does not work, and where the economies of scale are in information. And it's even worse in a way than you're saying, Steve, because kind of the property rights issues. I mean, Pfizer has an incentive to do a study of its vaccine, right? But to do a study of other things where there aren't property rights, like wearing a mask or using a thermometer or something, nobody has property rights on that. So that's, if there's a role for government, it would be in that area. But they certainly weren't stepping forward. In fact, that's how Emily got into the business she got into, is because the government was not doing these sorts of studies very, very much. And it seems like exactly their sweet spot that they didn't go to.
But Mike Boskin has the next question.
Yeah, thanks. Really interesting, Casey. A few observations, questions. Along your organization size, it seems one of the things that has been strained and a lot of finger pointing is the levels of government doing what, which is who is and should be responsible for what. You know, early on people were screaming Trump should have kind of nationalized everything and taken over everything. You know, like declaring the Alien Insurrection Act, et cetera. And our public health systems really kind of organized at a county, state, and federal level in their interactions. And so it seems to me that one of the issues is, and different states decided to follow different strategies, and that is something that many of us think is the strength of our federalist system. And then there are arguments that the federal government, maybe more now than when Trump was president, is trying to restrict who can do what and trying to sort of nationalize the rules or federalize the rules. So that's one dimension. And, you know, if the economies of scale, you know, if the variance of the outcomes goes up the size of the population, you know, you're going to wind up, you know, getting the standard deviation is going to flatten out pretty quickly as you get to the size of even a small state. So question is, what about the levels of government? And I want to pick up on what was just said about information. A big part of the problem is twofold. One is the public health officials tried to claim they knew a lot more than they did. And I think maybe they were afraid the public couldn't understand probabilistic statements, or they'd look vacillating and criticized for being indecisive if they indicated any uncertainty. And then secondly, of course, they turned out ex post to have been wrong on a variety of things. So it's kind of undermined the public's confidence in the public health system. So I applaud the idea of best practices, but in some sense, that's what the public health officials were trying to convey. And they, at least ex post, got it wrong sometimes and vacillated and undermined their ability to get the people to follow what they were suggesting because of the confusion and disagreements they had. So how does that fit into all this in terms of obviously strengthening private incentives? But if people are getting the wrong information and you don't get it out properly and quickly, all that. So how do you think about all that whole side of things?
And then we're doing this work. One thing I've been hungry for, maybe I'm missing where I can get it from, is some kind of analysis of more local externality. I have Samuelson's model, which is a pure externality and it spreads over the whole world, right? And this is a very local issue. And that's another reason why, not really captured in my analysis, why firms and smaller voluntary groups can maybe go a long way toward supplying what you want. I didn't have a real good framework for studying that. I would mention that when I was working for Trump, that he got experience before the pandemic on the federal system, and a number of more mundane policy issues he worked with letting the states decide. And he really got to like that. I think for political reasons and for the experimental reasons and freedom reasons. So it was pretty natural when the pandemic came along for him to think in terms of, well, each locality ought to think about what works in their own situation. So I think we got a little lucky there.
So Elena Postorino, please. Elena.
Thank you. Hi, Casey. A couple of questions. One is really a clarification about how your model works. So I understand that a central feature of it is that the demand for prevention activities per member tends to increase with group size. But I was thinking of it, your framework is embedded in an exchange economy. Suppose that we think about a production economy in which there are economies of scale if interaction increases among members of a certain group, like a large workplace. Wouldn't that be the case that the prevention demand per member doesn't necessarily increase, as there may be a countervailing effect from demand for larger interaction for greater productivity per member? And the second comment is about the planning problem. I was thinking whether you have any thoughts of an economy that consists of a collection of large organizations, like the one you're talking about, but there's a scarcity in the capacity of prevention resources. Think about vaccines in the early stage of the pandemic. What would be your thoughts about what a planner should do in that case? Thank you.
On the first point, I was thinking at the margin. So again, these weren't random lists of names that made these groups. These were groups that were already formed. And some of us work for small businesses, some for large businesses, and we had kind of sorted ourselves there. And yeah, large business could do some things a small business couldn't, but there were trade-offs, and that's kind of already there in the background. And so that's why layering the disease on top of that. That's not to say that big businesses don't have advantages separate from the disease. It's just part of that's in the background. I don't see the disease as changing that, although maybe I missed that part of it. So that's certainly not, that's how I analyzed it.
We see John Cochrane.
I just want to emphasize something you said, but maybe you need to say it louder. So much policy, people compare the danger of, say, COVID in school to an assumed zero whereas in fact, sending them home is more dangerous than in school, and you're better off forcing them to be in school as opposed to closing the school, even though there will be infections in school. That seems to be the kind of calculus that the policy is incapable of making. The slight question, that's just your conclusion restated. A slight question, though, we are supposed to belong to a group that internalizes externalities and has economies of scale, like government. There really isn't a reason to separate the institutions of a business or university from, say, the institution of a local government. But that we see such a separation, I guess, is just a huge failure of government in what Econ 101 says it's supposed to be great at, which is economies of scale, public goods, offsetting externalities, and so forth.
I would stress that households, businesses and families, these are groups that people formed before and work well. Whereas the government stuff's kind of based on geography, and it's a little bit, you're not in the California government with the other people.
Well, I'm in the city of Palo Alto government, which is supposed to be local and responsive, and
but it's based on some geography, not because you and your neighbor are good at doing stuff together. Unlike these other groups. Now, with that said, one of the puzzles I'm told in epidemiology, and it's kind of a puzzle this time, is why don't cities have more infection? And because the density is higher and stuff like that. I don't know if the same thing is playing out in that dimension as well. There's a long literature, I'm told, on that. And maybe it is I assume cities were some of the first things to get plumbing and water treatment and things like that. And as a result, the gradient could reverse for other diseases as well. And in the city context, then local government would seem to me to be a key actor in the analysis.
There is a key failure, though, which other people talked about. So you may have insight. Just the failure to give us basic data. What is the success rate of wearing an N95 mask? What is the ACE? If you just sample the water supply or do a random sample, how many people in Palo Alto right now are infectious with COVID? These would seem to be simple numbers that would guide all of our decisions, yet and very cheap compared to $5 trillion. We just don't have them.
They even tried to suppress, like when Jay Bhattacharya tried to do population testing. There was an outrage and trying to suppress it. Yeah.
But Palo Alto monitors sewage in real time.
But that number is not only not available when allowed, it's not presented. It's not, you can't have it. When you go down to Whole Foods, what's your best guess? Is it 1 in 100,000, 1 in 1,000, 1 in 100 of who's infectious? That's like the most important number to know for making decisions, and yet we don't have it.
No, it's true. The prevalence of this disease is quite low. On the order of 1 out of 500 or something. Maybe now it's 1 out of 100. And so a household's got no chance of, on its own, getting data on this. Their expected wait time to get the disease for one member is like a year or 18 months or something like that. And, you have to cooperate. And data is a key type of cooperation. And you wish our government agencies would be supplying that public good, but it's been limited.
It goes to, I'm sorry to think it goes to they're giving recommendations, but not why. Anyway, we're getting off track and other people are waiting.
Ned Prescott has a question. Ned?
Thanks, Casey. That's really interesting. I wanted to point out one aspect that your model, your analysis has that I think maybe, I'm not deep in the epidemiology literature, but it seems underappreciated is, there's a lot of disease spread through networks of contacts, and the networks vary by individual depending what organization they're in and who they interact with. And what's nice is you have something about how the organization may react, right, which is endogenous. Have you worked through sort of equilibrium implications of, let's say, if everybody, like half the country's in lots of large organizations, the other half's not, does that get R below 1? Or does it just delay how long everybody gets it? because there's still sort of externalities floating around between organizations as well, as people are kind of these sort of club organizations. So wondering if you've worked through some of those implications and thought through what, the implications of what you have at sort of the micro level sort of do more at the general equilibrium level.
Now, I haven't aggregated a lot of this. You see in the paper, there's a time allocation question that I dive into. I didn't discuss today, but that's still micro level, an individual just deciding, how much time I want to spend at the workplace versus home. But I didn't do that kind of aggregation, which I agree is interesting, and our comparative advantage that we're very good at looking at aggregates, understanding equilibrium. So there's lots of opportunity here for work.
So Caroline Hoxby, go ahead, please.
Hi, Casey. Thanks for a really interesting paper. I wanted to ask you about a couple of things that are affected by group size. The first one is a sense of potentially altruism towards your coworkers or whoever you're co-locating with. If you don't know people all that well, you may be more, regardless of their health than if you know them well. If you know, for instance, that someone might be immunocompromised or live with someone who's immunocompromised or something like that, and that requires a certain level of knowledge or routine interaction that's probably more likely in small groups. And then the other is really monitoring. So if I'm in a small group of nurses, I might know that someone had not gotten a vaccination, even if, she said that she had. Or if I were in a group of teachers or a workplace that's very intimate, I might be able to actually monitor and therefore provide some form of, I don't want to say retaliation because that sounds awful, but some sort of tit for tat. If you are not being careful yourself, and I can see that you're not being careful, I can decide to be less careful around you, or I can decide. So how ought we to think about those sort of dynamics that do change with group size simply because people have different interactions with other people or know less or more about someone else?
The cooperation is part of life, and the type of things that you talked about are an important part of life. And we have all these different ways that we interact and cooperate that we've developed over years and decades. And the thing I think is especially wrong in the policy was to shut down most of those institutions other than the nuclear family. It seems to be so destructive. At a time when you need cooperation, you're shutting off all the ways we've learned how to cooperate, which is not an easy thing to do, but we've been able to achieve that. That was why I started the talk with Mitchell. It's amazing what we can do when we work together, and we've done some of these amazing things. And to have a period of time we're not allowed to do that anymore seems to be bad public health. Forget about having all the non-health costs to it.
Casey, I have a couple questions. First of all, the data behind you are very impressive. And I wondered if are people learning from that? Or could you see that your study, other studies, that organizations are benefiting? Because, the red and the blue right behind you off your right shoulder is pretty amazing. The second is things are changing. The Omicron is much different from the others. That's really this year, is the way you can think about where we should be going. How do we adapt? How do your results apply to the current situation? That's another, and sort of on everybody's mind is how that's going to affect us generally. Are we going to do is hybrid teaching where it's going to be? Are we going to go back into classrooms? What is it going to be? I don't know. Those are difficult questions, but could you try to address some of those, please?
Well, the University of Chicago has not paid much attention to this. There are some other schools who have utilized this, and the North Carolina epidemiology group has been very good at reaching out to as advisors to various schools and universities. And especially in the school area, it's pretty easy to see getting kids back in school based this data making it easier to do that. You know, your last point, John, was you know what happens next.
Yeah.
You know, these groups were formed to do the things to make this deal or whatever Mitchell was talking about. And I'm worried that the groups are going to have to be rearranged because there's a new dimension to life that we hadn't sorted on before. Like concern about the invisible virus. And so now we have to sort on it. We have to sort on Republican and Democrat in ways that we didn't before. That's, I'm a little worried about what that's going to do to productivity, that we have to sort. If this is a permanent state of affairs, that we're going to have to resort on that dimension as well, which is going to be harmful to productivity and to have an extra objective and not any extra instruments to achieve it.
I mean, we've sort of gone backwards at Stanford, you know, in the sense of last fall I did in class 250 students with masks. This fall we're not allowed to do that, at least for a few weeks. So it's sort of reacting to the current situation. Anyway, I shouldn't go on. Jack Tatum has a question. Jack, you had the chat. You want to just say that out loud?
I was just wondering, you know, we did have an example of an innovation in the process when we introduced vaccines, and I wondered how that affected the range of cooperation that you're discussing.
I mean, the vaccine would make the disease less severe, and it would, you would think it would reduce prevention in other dimensions, and it probably has in a lot of ways, although I'm not sure Chicago has changed its prevention efforts in that dimension, maybe not Stanford either. Now, also the vaccine has a size element to it, so you have, you know, vaccine mandates at the workplace that you might not have in homes and maybe smaller organizations. So that may have a size element as well. Getting access to the vaccine probably had a size element to it. Because vaccine is an example of prevention. So it could be viewed as the X in my model, or you could take that as a give and put it into the V and ask how does the other prevention dimensions respond?
So raise your hands if you have a question. I have a question that's a little related to the fact you served in Washington, the CEA, for a while. And there's lots of criticism politically. Maybe you don't want to get into that, but can you say a little bit about what you might be doing differently if you were still there, or a little bit on the policy side? Is there anything you can address? Don't if you don't want to, but I'm very curious about that.
Well, we worked a lot before the pandemic on FDA deregulation. I mean, some of it was just more mundane. We would like prescription drug prices to be lower. So, well, let's remove entry barriers and prices will fall. I mean, that's what IO taught us, and we did it, and it happened. This is no surprise, IO works. And that had given us experience when COVID came along to have warp speed. You know, we had an executive order from CEA in 2019. You're hearing that right. In 2019, we had an executive order in the CEA report about vaccine innovation during pandemics.
Yeah.
We said the way to deal with pandemics is to have vaccine innovation. The thing I would have recommended to the Democrats, I don't understand why they can't do it. On day one, when Biden's inaugurated, they should have had a right to try COVID devices, pills, vaccines. They should have had a right to try a bill in Congress, and Biden should have been signing it on day one. I don't understand what the problem is. And that would help so many dimensions. I don't understand why it's partisan. I do. I worked in the government. I understand the bureaucracy rules, okay? But from the rest of us who aren't in the bureaucracy, it's just so frustrating that we couldn't have a right to try. And it's not something it's not a new idea. States have done that before. Like I said, we were doing it in the Trump administration. Why can't we be doing that? And I wish we would have had the vaccine quicker. You know, March 16th, 2020, we closed the schools. Supposedly that's something we can do quicker than innovation. Wrong. The vaccine first went to humans on March 16th, 2020. So we should have been passing out the vaccine to anyone who wanted it. It would have been a smaller group and everything. But through that summer, people would have been getting vaccinated, the more courageous, and people would have been following on. You wouldn't have the supply constraints in the winter on the vaccine because it would have been distributed more slowly and more evenly through time. So even Operation Warp Speed was too slow in my view.
Thank you. So Bob Hall, Steve Davis, and Mike Boskin. Bob, go ahead.
So you threw out one very interesting fact, which didn't seem to play any further involvement in this analysis, but seemingly could, and that is that the typical time to infection at the household level is about a year. So that's just the reciprocal of the flow probability of infection that you mentioned. And that raises an interesting question that's been raised by many analysts but not answered, and that is, are we talking about just postponing what everyone ultimately is going to be infected? It's just a question of when. That's one scenario. Or another one is that we could deliver perpetual avoidance. And one thing we've learned recently is that you don't get perpetual avoidance either from getting infected or from being vaccinated. So is there any way to put the whole analysis together and answer this fundamental question of whether we're talking about just postponing, flattening the curve, people used to say, or are we actually protecting some people like me, who has yet to be infected, and in which case there's much more value at stake than if eventually everyone's going to get it. It's just a question of when.
Innovation is the number one thing. We said that in 2019. I'm going to say it today. Innovation is the number one thing. That means the future is going to be better than now. So if you can delay an infection from an individual point of view or from a group point of view into the future, you'll be delaying it into a time when the vaccines are better, the treatments are better. Now you will be older. We'll all be older in the future, so that may be going the other direction. But the innovation's pretty impressive, and as long as there's incentives to do it, I very much count on it.
But my question is actually, do you have some kind of you have all these per period, per day or whatever infection rates, but you don't seem to have a model that is a dynamic model that plays out and answers this question. As of 5 years from now, what fraction of people will have been harmed by this virus, and how does that differ if we hadn't engaged in some of these mitigation strategies?
No, we don't have that. I mean, a lot of people in our profession have done that. Murphy and I and Papell had a little something where we had a dynamic analysis, particularly paying attention to innovation that's coming.
Could I just add on this point? I mean, there's standard SIR models, even if you don't do anything, don't have everybody get infected. The standard SIR models, there's a wave, and then the wave goes away, and then it's still there, but it's at such low level that the rest of the herd doesn't actually get sick.
But there are SIR models that deal with things like influenza, where the base level is permanently quite positive.
Yeah.
So the SIR model is not inherently incapable of dealing with that question.
It's not. We don't get to the stage that everybody has it in a standard sort of SIR view. Even influenza, lots of people got it, but then it went away, and lots of people never got it.
Yeah. Well, a lot of experts say that ultimately this virus is going to turn out to be just influenza-like, and there'll be a season. I guess January when I think it's more serious.
So let's go.
Every January, the same number of people will die.
Let's have. So Tom Hazlett, you haven't spoken yet. Go ahead, Tom.
Yeah, thanks, and obviously quite interesting. So these large organizations that pursue some mitigation measures and have some incentives to innovate and some economies of scale, and you listed out some of the things they do. and you know, you think about large universities, they've done a lot of testing. That's you know, really what has driven a lot of that policy. But I don't know. It doesn't seem to me that they're providing any medicines. Now, you know, monoclonal antibodies and, you know, some other stuff has been approved for this. Is it federal regulation that has intervened to stop that? Or perhaps it's that those organizations don't internalize as much gain from that. Once you're out of the workforce, they're kind of downloading you to the community, and you know, they're mitigating the problem with their workforce, but maybe they don't have the same incentives to go out and make big purchases of the various drugs that are available, and so the treatments have lagged.
Well, there is definitely regulation that is a tremendous barrier to treatments and vaccines. I think the universities did get involved in administering the vaccines. They didn't. Now, Oxford was involved in inventing it, but most of our universities weren't involved in inventing it, but they were involved in administering. I know in Chicago, even a lot of the people in the neighborhood got their vaccine through the university in the early stages.
Yeah, that seems right. But anyway, so in terms of treatment, and you know, maybe I'm wrong, but it appears to me that we've way undertreated, and the remedies that are available have just been rationed. But you think that's federal rationing?
Yeah, I mean, there's also this idea that the government ought to own all the treatment and pass it out. I mean, that's a disaster. The government is not a good distribution network, but they, like the monoclonal antibodies, I believe they all go through to the government. They're sold to the government and then delivered to the people. And it's based on politics. It's based on incompetence. That's not been a good situation.
Yeah, well, correct me if I'm wrong. Maybe you don't like the cut of this, but I do remember when President Trump said that when the vaccines came, this is shortly before they were at the point of being released, he said, don't worry about getting those vaccines out. I've appointed the military to do it. And yeah, I thought, oh my God. So it ended up going out in different directions, but it did have that, there were obviously glitches there as well.
Now, one of the things I regret in doing that 2019 report, an executive order, I wish it had done more on the distribution side. The reason, it's not just hindsight. We were working with Obamacare, which itself was a disaster. I mean, talk about ruining a brand. I mean, Obamacare got us a position where people would not, you couldn't even pay them to go on insurance. The brand was so ruined. And I wish we would have applied that to the vaccine. We say, okay, in a pandemic, we need a vaccine, and let Madison Avenue market it. Don't let the government market it, because they're going to ruin that brand, and that's going to be harmful to health.
So Steve Davis, your hand went down. You still have a question? Sorry.
Let's let Mike go first. If we have time, I'll go.
Okay, Michael, go ahead.
Yeah, so you guys, you and Tom were talking about regulations, but a really big mystery is why there wasn't an Operation Warp Speed 2.0 for therapeutics and tests, especially since then candidate Biden spent most of 2020 criticizing Trump for inadequate testing. Do you have any idea of what's going on there?
Yeah, the bureaucrats run the place. That's the bureaucrats. 99% of the
FDA
bureaucrats.
and the CDC were so focused on vaccinations, they don't want to have a mixed message, or what's going on?
No, I mean, to get warp speed, I mean, the bureaucrats had to be brought into line. I mean, that's not, the bureaucrats didn't want warp speed. I mean, they want to go slow. I mean, they have all their incentives are, you know, to go slow and be careful, and speed, it doesn't matter. And 99% of the bureaucrats voted blue in these elections. I mean, what can we say? The bureaucrats, the teachers' unions, the Democratic Party owns them, and that's what's going on. That's beyond my expertise in this paper, but that's my view.
There was some allocation of warp speed for therapeutics, not just vaccines, and and again, we've gotten some progress on that, but they're not being distributed.
Well, also apparently, I'm told Pfizer went to the government and suggested they do the same thing for therapeutics they did for vaccines and have big purchase orders and help them ramp up production. And they demurred. So I don't know. I've heard that from several people. I don't know. I have no firsthand knowledge of it.
Steve?
Yeah, so I've been trying to formulate a question related to your remark about cooperation, private sector cooperation cases. This may come out half-baked, but when I start to dissect what cooperation means in the private sector, well, there's different ways to cooperate. There's kind of voluntary exchanges through the market. There's organizations that try to internalize the external effects you were talking about. But if you start shutting those, and there's compulsion, compelled cooperation from on high. But if you start shutting down some of the private sector alternatives, the good ones, you might get negative ones. So I think about shame and disdain and vitriol being spewed as a way to try to coerce cooperative behavior. There seemed to be quite a bit of that during the pandemic, and viewing people who did not go along with whatever the correct approach, wearing masks, whatever was, as being criticized socially and ostracized. And so what I'm trying to get to is that a consequence of the fact that we shut down, or do you think that's a consequence of the fact that we shut down more productive, voluntary forms of cooperation? So anyway, I said it's not a very well thought out question, but I think there's something there about just what cooperation means, and that there are multiple aspects of cooperation, some of which might be more attractive than others.
I mean, it's the other side of the coin. And when I was addressing Taylor's comment about it, I said, isn't it too bad we have to resort on some of these things now? But the other side of the coin is, thank God we can resort when the mandates and things are coming from a private organization. So if I don't like how Chicago does stuff, I can leave Chicago. And thankfully that we have that option. And that's one of the beauties of the organization, voluntary groupings, voluntary cooperation that happens, that people can move it in and out if they're harmed too much by what's going on. Yeah, their scope isn't the whole economy, and that's a disadvantage of that, but the freedom is a big advantage, and the groups need to offer value to everybody. And that prevents a lot of harm. It's a really nice safety valve on things.
Casey, one thing you didn't get into, but it's probably on everybody's mind, is international situation and what other countries do. Is there data similar to yours that we can get from other parts of the world? What's your sense of the global aspects of this study?
I was doing Google Scholar, so that was in English, so that's a bit of a limit. I found a lot of things on schooling, and they're included in this paper and the schooling paper and public choice that I cited there. Less on the business side.
Right.
I don't know if they're not gathering the data or it hasn't hit the journals yet. But presumably things were being learned in foreign businesses too. Yeah.
Okay, I think I don't see any hands raised. I say Ellen has a chat thing. Maybe it's a long one though. Maybe you could come back later. You want to say something briefly about that, Ellen?
Yes, yeah. I think it's very important the point you made that we have to understand the differential incentives to prevent among large and big groups. But I was involved in conversations in Italy within some governmental institutions about this. And one issue that came up repeatedly was, but do we have the same preference over prevention activities? And so I'm thinking whether there is a micro foundations behind your F or other efficiencies of environment that implies that there are benefits to larger sites in terms of public good provisions. But what if we don't agree? What if we have different informations about the cost and benefits of different prevention activities? Or what if we have different preference? I may not mind prevention activities the same way that you do. does your theory apply to these cases, and what are your thoughts? Thank you.
You know, of course, we have differences. I mean, this is always the challenge, and that's why we have home. We don't want to be in these groups as much as we like Schultz's policy group, right? We don't want to be in this group all the time. We want to have some privacy sometimes, you know, and that's something that we've been dealing with before the pandemic, is my point. And we had developed groupings and mechanisms and chains of command and things like that to deal with those trade-offs. And you would think you would want to leverage them from a policy perspective instead of shut them down.
The idea is that the more similar we are, the more common our demand may be, and the better able we are to enforce prevention activities ourselves. Is that fair?
Yeah, I agree. And you see a lot of the sorting you saw before the pandemic was pretty similar people working together, being married to each other. You know, pretty similar people. Not identical because they were trading with each other, but pretty similar.
Thank you.
Casey, we're about out of time, but thank you so much for drilling down like nobody's drilled down before. So have a better sense of what's going on. Appreciate it greatly. So thank you for joining us. Thanks for your interventions. Thanks for your answers to the questions. Bye-bye.